So hopefully we're going to spend about an hour reviewing Section H, which is a new section in the 1.4 version of the IRF-PAI. We have about 60 minutes, and hopefully we'll leave some time for questions because we know there'll be questions. I am hoping that I thought of a lot of them as a provider. We did go through things and started to try to think like you, because we are like you. So we did try to come up with some questions ahead of time, and hopefully I'll touch upon them in my talk, and then if not, we can certainly review them. Okay, so on to Section H. Oh, that's me. Okay, so as we begin most of the sections, we're going to review a little bit about what our objectives are for this session. We're definitely going to want to make sure that you walk away with a knowledge of what Section H is, why we're introducing Section H, and why we need to complete it. We're going to interpret the coding options for this new item set, and we're going to apply those coding instructions and do some practice scenarios. And I'm very excited. I haven't done the polling yet, so I'm very excited to try the polling. Okay, so Section H is a new item. If you look at the IRF-PAI that you have at your tables, if it's still there, it's page 10, and it's way up at the top. And it might be helpful if you kind of pull it out and sort of follow along. So both of the items, H0350 is bladder, and H0400 is bowel continence. And both of those are assessed only on admission. I'm wondering at this point if anybody in the audience can tell me why they're only assessed on admission. Because they're used as risk adjusters, and we've heard that from other speakers before. So it's a common theme, and it is used to adjust the risk for the mobility and the self-care items. So you only need to do it on admission. And the intent is to gather information on bowel and bladder continence. Seems pretty obvious. So let's start with bladder, our favorite. Okay, so why do we care about bladder incontinence? Why is it even a concern for us? And, you know, standing up here talking to most of you out there, it seems kind of silly that I even have to say this because I know you all know the reasons why. Bowel and bladder continence is really something that we pay a lot of attention to in IRFs. We recognize what it means to patients to be incontinent and how it affects their lives. It makes it difficult for them to participate in certain activities if they're concerned that they're going to be incontinent. It can lead to some social isolation. I don't know about you guys, but we have patients who tell us sometimes, you know, I really am uncomfortable leaving the house because I don't know when things are going to happen, and so I just kind of tend to stay home, and that's unfortunate. They are at risk for a longer length of stay, which none of us want, that's for sure. And they are certainly at risk for any skin breakdown and issues related to that. So in the facility that I work in, we have a very large multiple sclerosis population. We have a multiple sclerosis comprehensive outpatient center, so we get a lot of multiple sclerosis patients, and they are at huge risk of urinary tract infections repeated, and a lot of them suffer from, you know, bladder incontinence as well. So we see a lot of it. And we all know that because a patient is incontinent, they are at a higher risk for falling as well. And that's another area that we pay a lot of attention to and is really important to those of us who work in IRFs. So this is a great item for us. For many patients, you know, bladder incontinence can be resolved or at least minimized. And again, talking to the group of people that I think work really hard at managing these symptoms and attempting to resolve incontinence. So I know you know all about that. We want to identify and treat any underlying potential reversible conditions like a urinary tract infection, and we certainly want to eliminate any environmental barriers to folks being able to get up to a commode or to the toilet. And again, that's something we work together in teams. We have our physical therapists work on bed mobility, our occupational therapist works on, you know, toilet transfers, and our nurses are diligently getting patients to do those activities. So I think we're ahead of the game here. So how are we going to assess for this item set? We're certainly going to review the medical record for any documentation of incontinence. You know, Every facility has a different way of doing this. You're going to want to look to, where you capture that information, whether it be a nursing flow sheet or whether you have your CNAs document it. But I do want to make sure that you include, everyone on your team, certainly the nursing assessments and progress notes, but a lot of our physical therapists or our occupational therapists are often the first ones in the patient's room in the morning, and they can identify if the patient had been incontinent overnight. So you want to make sure you include everybody on your team, and certainly the physician history and physical as well. So we're going to interview the patient, certainly to see if they are able to tell us if they've had some incontinent episodes or their family members. And we're going to also ask the direct care providers, like I said, certainly all the members of your care team. I did want to point out specifically that intermittent catheterization, which is commonly used in our environments to drain the bladder, we're going to code incontinence level based between your straight caths. So, in other words, if you're working with a patient, a spinal cord patient, or we do it with our MS patients all the time, we'll start teaching them how to intermittently straight cath as a way of managing their bladder. But we always, it's a process. So sometimes we'll start with maybe straight cathing them every 6 hours, but we find that maybe they'll have an incontinent episode in between those straight caths. So we are going to want to keep track of that incontinent episode between the straight caths. As we get better and better in planning with the patient and identify, what their intake is, what their pattern will become as they move through rehab, oftentimes we can resolve that incontinence in between our straight cathing. So the item is H0350, and the coding instructions are included during the 3-day assessment period. So it's the first 3 days of the patient's admission that we're going to want to capture this information. And keep in mind that 3 days, I think Ann mentioned it yesterday and it was clarified a couple of different times. So if a patient comes in on Tuesday is day 1, Wednesday is day 2, and Thursday up to 11:59 is day 3, okay? So when we're looking at this item, I mentioned when I was here yesterday morning, the difference between coding and scoring. And again, I personally love that distinction, and I'm going to use it a couple times this morning. So we're going to want to code these items. You're going to code a 0 if the patient is always continent during the 3-day assessment period. So every single time that they've released their urine, they've done it voluntarily, and they've done it in a bathroom or toilet, commode, or wherever. You're going to code a 1 if the patient has stress incontinence only. So if during the 3-day period the patient had an episode of incontinence that was associated with a physical activity or coughing, sneezing, jumping, I don't know how many of your IRF patients are jumping, but if you have one, good for you, or any lifting heavy objects, or sometimes I know in physical therapy, sometimes if they're doing abdominal exercises or leg lifts, I'll walk by the gym and I'll hear someone go, whoops, yeah. So it does happen sometimes in the gym as well. You're going to code a 2 if they're incontinent less than daily. So over that 3-day period, they had some incontinent episodes, but it wasn't at least once every day. We're going to code a 3 if they are in fact incontinent every single one of those 3 days, at least once. A code 4 is when the patient is always incontinent. So they've not had any continent episodes in the 3 days in which they've been with you. A code 5 is used when you have a patient who has no urinary output at all. And we have 2 renal access beds in our facility, so we oftentimes have patients with end-stage renal disease. So we do on occasion see patients who just don't produce urine. So if you do have a patient who does not urinate, you're going to use a code 5. Now again, this doesn't mean patients who should be voiding and haven't voided in 3 days, then you've got a problem. But these are for renal patients. And a code 9, which is considered not applicable, if during the 3-day assessment period the patient had an indwelling catheter, condom catheter, or ostomy for the entire 3 days. Okay, and we'll talk a little bit more about that as well. So I wanted to kind of emphasize a little bit about stress incontinence, because when I first read through this was something that kind of jumped out at me, because it's new for us, and it's not something that we've been, paying a lot of attention to as a documentable measure. We currently at the facility I work at, when we have a patient who's incontinent, we do try to figure out why they're incontinent. Is it functional incontinence? Is it overflow incontinence? Is it stress incontinence? Because the best way to treat that incontinence is to really understand why it's happening. And for this measure here, we're going to look at stress incontinence, and it's defined, as a small leakage of urine associated with these types of activities. And in speaking with Ann and with some of the folks at RTI who created, the measure, the intent really is not for you to spend, hours upon hours, or the CNA running into the bathroom every time I go into void to check to see if I've had some stress incontinence. That's not the intent. The intent is really to eliminate from the rest of the incontinent episodes a patient who has stress incontinence. So I don't know, does that make sense? So in other words, I think of my mom, who's 82 years old and gave birth to 5 children. She walks around all the time with a little something going on. If she jumps or walks, she's amazing. She's 82, walks the beach 5 miles, lifts, because she might get osteoporosis. And she might present as someone with a little stress incontinence. She would not be someone you would record as incontinent daily. Do you see the distinction? So we don't want you running back to your facilities and trying to figure out how are we going to capture this very specific type of incontinence and compare that with what is the real incontinence that we're trying to get after. Does that make sense to people? And hopefully that alleviates some of the questions that may be coming later. So for coding tips, we want to remember for this item, we're looking at just the 3-day assessment time. Now, we currently score other items on the IRF-PAI, and we know that for those items, we look at 7 days. And we'll talk a little bit about that, because you're going to want to make that distinction when you go back to do your training. Incontinence is, basically an involuntary loss of urine or leakage, and you want to review all the documentation and discuss with staff to determine the frequency. So for this item, you do want to make sure that you do have a way of reviewing or looking back through your documents, so whoever is going to be completing this item for you on the IRF-PAI can retrieve that information either from the medical record or at least be able to talk with staff. So depending upon who you have in your facility doing this, you're going to want to kind of go back, and we'll have you pull out your action plans later, but you're going to want to make sure that you can retrieve this information so you can figure out whether it is daily, whether it's always, or whether it was just stress incontinence, okay? So that's an important thing for you to remember. Okay, so we're going to try a coding scenario, and we decided this wasn't probably the best scenario, but it's here and we're going to use it now. I'm going to put my mother, I'm going to ask to see if my mother can go in the coding manual next time. So Mrs. M is an 86-year-old patient who has long-standing stress incontinence for many years. When she has an upper respiratory infection, however, and is coughing, she involuntarily leaks urine. However, during the current 3-day assessment period at your IRF, the patient has been free of respiratory symptoms and therefore has not had an episode of incontinence. How would you code H0350? Okay, so let's see. So, whoops. Okay, so for this patient, you would code 0 that she is always continent. Now, the reason this isn't the best example is we probably should have put that, she has stress incontinence, and while she was there, she had stress incontinence. But I guess the piece we wanted you to kind of keep in mind is that a couple things. One is if a patient does have stress incontinence, but they are not incontinent in your facility, then you're going to code them as a 0. Okay? Everybody with me still? Making sense? I'm looking at, I see some heads nodding. Okay, good. Okay, so let's try another one. So Mr. A is recovering from a traumatic brain injury. So he was incontinent of urine twice on day 1 of the 3-day assessment period, once on day 2, and once on day 3. So how would you code H0350? I hear a lot of 3s. That's right. So the patient would be coded as a 3 because he is incontinent daily. Now, you could argue that potentially he would be considered always incontinent if the IRF-PAI coordinator or the person you have completing discovered that those were the only episodes he ever voided, which is unlikely. But if he had only voided twice on day 1, and he had only voided once on day 2, and he had only voided once on day 3, he could have been always incontinent. In this example, we didn't explain that he voided a couple of different times. Am I confusing you or clarifying it for you? Okay, good. All right, so we get to use our polling devices. I'm very excited about this. Okay, so this is my first one, so bear with me. So you got your devices out? Everybody knows where they are? Okay, I'm seeing some heads nod. Okay, so Mrs. T had 1 urinary incontinent episode during the 3-day period. All other voids were continent because we have a really great certified nursing assistant following a timed toileting schedule to assist her to the toilet, because we all know that that's hugely helpful when they do that. Okay, so let's see what you think. How would you code H0350? And I so want to sing the Jeopardy thing. Do 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 do. I've wanted to do that for 2 days. Thank you. Okay, so we'll start the clock. I guess I should have done that before I sang the Jeopardy song. Okay. Everybody kind of ready? Give me a nod. Yep. Okay, good. I'm seeing nods. So let's see. Do, 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 do. Now I got to do the Twilight Zone song. Yeah. Oh, people weren't using their devices. All right, very good. That makes me feel better. I was going to cry. Thank you, thank you. Okay, so the correct answer, as 88% of my new friends tell me, a code 2, incontinent less than daily. Does that make sense to people? Yeah. We're still waking up. Okay, and the reason is that the patient did have 1 incontinent episode during the 3-day assessment period. Okay, let's try another one. Mrs. W had an indwelling catheter that remained in place during the entire 3-day assessment period, and there were no episodes of urinary incontinence. Okay, so how are we going to code H0350? We'll start the clock. And I am not going to sing. Everybody, that's pretty straightforward, this one, right? Yeah. 98%. Woo! And the correct answer is code 9. That's correct. So it's not applicable because we had the patient with a Foley catheter for the 3 days. Now, the $1 million question is, what happens when we take it out, right? because we're good at that. We get a lot of patients admitted with catheters on day one, and we don't leave them in. So on occasion we do. If the urologist is asking us to do that for a variety of reasons, we do. But for the most part, we're really good about taking them out. So how will we code this in those circumstances? And I did have a long conversation with Ann about this, and we talked about it. So if you take the catheter out on day 2, the patient arrives in your IRF, she's probably right, on a Friday night, right? And Saturday morning, you got a great physiatrist who comes in to do his PAPI, his post-admit physician evaluation, and he says, take the Foley out. At that point, you need to begin to assess the amount of incontinence or the episodes of incontinence. If it is every single incontinent episode, then the patient is always incontinent from that moment on. If it happens once each of the days, you can use incontinent daily. So you can apply the item after you remove the catheter. And it should be, based on your assessment, clear which you should code, okay? I mean, we will have some patients who have the catheters in, but I think we're pretty good about taking them out, so.